next 15, 20 minutes, I'm going to share with you the experience is nothing guidelines, don't worry about. It is guidelines, but it's based not in clinical trials or anything. You don't expect clinical trials in pregnancy to show that a drug X is safe or not safe. It's based on experience and accidental exposures. But before I do that, and I have to use as the principles we use to reach these conclusions. What's the principles we have about drugs and pregnancy? The first principle, don't expect clinical trials. No patients or no individual will accept to be exposed to drugs that you don't know the safety or minimal safety of these drugs, okay? So don't expect clinical trials. It's not based in clinical trials, okay? Second, don't extrapolate what happened in animals. Obviously, drug companies, they have to test all drugs in animals before they bring into human beings. So don't extrapolate what happened in animals to human beings. For example, steroids. Steroids has been linked to cleft palate in animals. No evidence for that in human being, okay? So it's a good example for don't extrapolate what happened in animals to human being. Most drugs cross the placenta, so be careful. In theory, most drugs should be able to cross the placenta, especially in the second and third trimester, okay? Greater risk in the first trimester, and the reason for that is organogenesis. The organogenesis occur between 6 to 10 weeks, and therefore you expect a problem. If there is a drug is going to be teratogenic, it will be teratogenic because exposure in the first trimester. What we don't know, the effect of these drugs in the long term. If a mother exposed to azathioprine, there is in theory risk for the baby, female baby, in theory, okay? There is no evidence for that. She could have problems with the ovaries because it could be toxic to the ovaries of the offspring of these mothers. We don't know. We need to wait for the mother exposed to azathioprine during pregnancy for the children to get married and to see if there's any problem on that. So long-term effect is not known for those mothers who are exposed to the drugs. And always remember, we have very bad habit in medicine, extremely bad habit in medicine. When things goes wrong, we publish, okay? And that biased the literature. In the 70s and 80s, patients with lupus nephritis were asked actively to terminate pregnancy, okay? Not in Kuwait, obviously, it's in abroad. And the reason for that, because there is a couple of publications where the mother died during pregnancy because she had lupus nephritis, or she had ended up in end-stage renal failure because she had lupus nephritis. And the feeling was, if you have lupus nephritis, forget it. Don't get married, have a dog at home. Don't have babies, okay? And that was based in biased cases that we published in the 70s and 80s. Because if you send to the New England Journal of Medicine in the 70s, I have lupus patient, she had lupus nephritis, she fell pregnant, she had baby. And the journal will tell you what's special about it. She had lupus and she had a baby, so what? But if the patient died, you might publish the case, you know? And this is the problem. In the 80s and 90s, when series start publishing, showed, hey, lupus pregnancy is a high risk, especially with lupus nephritis, but it's not contraindication and you terminate pregnancy, okay? Second principle, and this is worries the patients and the doctors. Many doctors, they don't have experience about drugs in pregnancy. They're worried about the patient taking drugs, and they tell her, oh, stop all your drugs straight away. Stop all your drugs. Don't take anti-rheumatic drugs. They are toxic in pregnancy. And the mothers, obviously, they read. They have access to the internet now, and they tell you, well, from aspirin to any drug you think of, the drug company will never say use in pregnancy. They will tell you stop in pregnancy. If you rely on the internet and what is written in the prospect of the drug, they will tell you stop all medication. And many females do that. They have anti-rheumatic drugs, important drugs, they stop them without even telling you, okay? The third principle, and this is important in my field, an active rheumatic disease, an active lupus nephritis, for example, is much more dangerous to the mother and to the fetus than the potential toxicity of the drug. So if you use that principle, and this is what we use to gain experience over the years, then we have some experience about the drugs, because the drug is less toxic or less potential toxic than the disease. If you leave active lupus nephritis without treatment and during pregnancy, you face a lot of problems, believe me, okay? Okay, so where's the data come from? If we don't have data coming from randomized trials, by experience. And this is one of the many studies that I did. It's 29 authors, you can see it there. 29 pages. We came up with document 29 pages. Very good. We reviewed the whole literature about every drug you think of, from animal models, toxicity, and so on in humans, but it's not practical. And secondly, is very, very based on opinion, people who work in the field. So how is this going to help you? It would help a little bit, but it's not practical. So what we did, and here has become my message today, this one. This is very important. Why is it very important? Because if I came here 3 years ago, I didn't have this slide with me, okay? I would tell you, this is my experience, this is what I say. But if one of your patients sue you and take you to court, say, you told me azathioprine is safe, and you'll say, well, Dr. Khamashta came to Kuwait and he said it's safe. He said, who's Dr. Khamashta to say that? Here, you have your society defending you, saying, it's not Dr. Khamashta said that. The British Society of Rheumatology committee said that this drug can be used in pregnancy. The EULAR, European League Against Rheumatism, they form a committee, and they said that. And this is different trade now. So the commission asked us, this society asked us, as expert, to review what we have available and to suggest some drugs compatible, some drugs are not compatible. So the lawyer, you give him the document, and the lawyer will be happy to accept that. Not Dr. Khamashta say, the society says, okay? That's very important. I participated in both of these studies. It took us 3 years to do. I prefer the British study for a lot of good reasons. First is practical. You can download it. It's in the abstract book. It's free. It's 3 pages, not 300, not 29 pages anymore, okay? So what you need to know about each drug, safety before conception, if it's interfere with fertility, safety first trimester, safety second trimester, safety for breastfeeding, and if my husband takes the medication. If my husband takes methotrexate, can I fall pregnant, okay? So these are questions are very important, and you have 3 lines about each drug. So you can download it on your computer or on your mobile phone to have it as reference, okay? And we looked at anti-rheumatic drugs, and also we looked at antidepressive, Lyrica, and other medications that we use in rheumatology to help patients with their depression, with tramadol for their pain, and so on, about the safety of these drugs. But obviously, it's important as well to note what we have NICE there, okay? Which is important. If you know what NICE is in UK, this government body, he looks at that, and we managed to have NICE stamp, which help us to support what we are saying, okay? So this is very important document. Please have it in your computer, not because it's mine. It's very helpful. Quick look. It takes 2 minutes to show you whether methotrexate is safe if your husband take methotrexate for psoriasis, for example, okay? This is the summary of this 3 years of work, okay? We are lucky that many of the drugs we use to control rheumatic diseases, many of them are safe in pregnancy, are compatible with pregnancy. Look, paracetamol, low-dose aspirin, sulfasalazine we use for inflammatory bowel disease and for rheumatoid arthritis. Non-steroidal anti-inflammatory drugs until week 32. We can use hydroxychloroquine is a vital drug. Please don't stop it in pregnancy. It's a very safe drug in rheumatoid arthritis and lupus. Prednisolone. If we need pulse steroids during pregnancy, it's safe. Azathioprine, cyclosporin, tacrolimus, colchicine, IVIG. Why I put anti-TNF in green? Because until 3 years ago, it was don't use, okay? Now, thanks to registries, not only in England, registries in Germany, in Spain, in the United States, suggest, hey, these drugs are vital drugs, are important drugs for inflammatory bowel disease, for uveitis, for rheumatoid arthritis, and the generated data we have so far suggest, please, don't remove them from there. Not anymore should be there. They are useful drug to put them there. And I will spend some time on this because all of this is old news. This is new. This is totally new. Not compatible with pregnancy, cyclophosphamide, methotrexate, and mycophenolate. Why they are in different color? They are in different color because they are teratogenic. These are 3 teratogenic drugs, should be stopped before contemplated pregnancy. The other drugs, hey, if a patient falls pregnant accidentally with leflunomide, don't panic. It's not a big deal, okay? Stop it and continue a pregnancy. The other 3, you have to be careful about malformation. But the other drugs, because of lack of experience. They don't use, not because they are toxic, lack of experience. Mepacrin, COX-2 inhibitors, rituximab, belimumab, tocilizumab, abatacept. They are in that category, don't use for lack of experience. But the really teratogenic, the first three, okay? Should be stopped before pregnancy. Let me tell you about biologics, because it's the only thing new. The other thing is old news, nothing new about that. So biologics, the best one we have experience with is anti-TNF. It's 15 years of experience now. Some of them are biosimilars, i.e. they lost the license, they do it in Korea and they do it in India at 25% of the price. They are very expensive drug. We have now biosimilars to replace them. Has been used for 15 years, and we gained a large experience with these drugs. The other biologics, we have 9 biologic license for rheumatoid arthritis, okay? 9 biologic drug license. So we need to know about their safety. And these drugs are also used by gastroenterologists for inflammatory bowel disease, okay? So as I said, the largest experience with anti-TNF. We have 5 anti-TNF licensed, all of them being used in rheumatoid arthritis and inflammatory bowel disease. But there's differences between them. Anti-TNF, that the 5 we have, etanercept is fusion molecule. All of these, they have the FC fraction of the antibody, with the exception with cetrolizumab, which is Cimzia, which is only the Fab fraction of the antibody. There is no FC part of the antibody, and therefore, very little pass to the baby. You need the FC receptor to pass to the baby. So very little with this monoclonal pass to the baby. Do we have evidence for that? Yes. Remember, the antibodies to protect the baby come from the mother. So the concentration of the antibodies mother to baby are much higher in the babies than in the mother. If you look at the infliximab and adalimumab, after 20 weeks of pregnancy, for example, 30 weeks of pregnancy, is much higher in the baby than in the mother herself. For the case of etanercept and cetrolizumab, is just very little passed to the baby. So if I need to use one of these drugs, I prefer to use one of these 2 rather than the other one, because the concentration of the antibody passed to the baby is very high, and the other 2 is less or very negligible, okay? Now, where does the data come from? As I told you, from registries, and for the EULAR task force, when we did the recommendation, we reviewed this. There's more than 2,000 is a large number of patients exposed to these drugs during pregnancy, different stages of pregnancy, and you have the details in the slide. So as I told you, you have the app there. You can download the app, and you see the safety about these drugs for your daily practice. But let me tell you about the unresolved problem for our clinical practice, okay? As I told you, the concentration of these antibodies is very high in the baby, is about 180% more than the mother, especially for infliximab and for adalimumab, okay? So this is, for us, create a problem that you will find a concentration of this in 9 months after delivery. So the baby still have the antibody there. So what's the implication of this for vaccination? So in theory, if the mother exposed after 20 weeks of pregnancy to one of these monoclonal antibodies, you should avoid live vaccine. So we have problem here. We have already problem. As I told you, there's 5 monoclonals. At least 2 of them, if the baby is exposed to that drug, you might face the problem to avoid live vaccine in the neonate. This problem is being tackled by 2 international studies. Obviously, the leaders of this, gastroenterologists. Why is that? Gastroenterologists, they are aggressive specialists in the sense they don't allow for inflammatory bowel disease ladies to fall in pregnancy without treatment. So they decided a long time ago, we think anti-TNF is a safe drug in pregnancy. So they have a lot of anti-TNF, and they have large experience about anti-TNF in pregnancy. So while we are talking, there is 2 international studies running to show the safety of anti-TNF and vaccination. It's very important studies. I don't have data to share with you, but these are ongoing studies. For the time being, for the time being, as I mentioned before, taking into account the passage of these antibodies from mother to babies, etanercept and cetrorelizumab are the safest to use. However, having said that, all of them until 20 weeks are safe to use. In other words, if one of your patients, whatever one of these 5 drugs she is taking, fall pregnant, don't panic. You still have time until 20 weeks to stop it. All of them are safe until 20 weeks of pregnancy. After 20 weeks, if I have to choose, I will choose one of the 2 drugs that we know that negligible amount will pass to the baby. So this is the recommendation about anti-TNF. More than 2,000 patients have been exposed to this, we know from registries. No data about biosimilars. I told you there is biosimilars hitting the market. I don't think in the Arab world we have them, but in England is full of it. In Europe is full of it because it's much cheaper drugs than the originator's drug, okay? We don't have data on about biosimilars. The TNF inhibitors are at low risk. The benefit of maintaining remission versus active disease, I think, is low risk. If I have to give any of my patients these, I will give it until 20 weeks, as I said before, and reassess the need of giving the drug after 20 weeks. If I need the drug after 20 weeks, I will choose between the 2 drugs that I know they are safe later in pregnancy, etanercept and cetrorelizumab. What about breastfeeding, which is also tackled by the BSR and the EULAR guide recommendations? As you can see, happily, we are using drugs, they are quite safe, including anti-TNF. So don't deny the mother the chance for breastfeeding because she's taking any of these drugs. Cyclophosphamide, mycophenolate mofetil, methotrexate, and leflunomide are formally contraindicated because they pass through the milk from mother to baby and therefore could be potentially toxic. But the rest of the drugs that we use routinely to manage lupus, rheumatoid arthritis, inflammatory bowel disease are allowed during breastfeeding. In the end, I have to say this is Kathy Nelson-Piercy paper, it's a compromise. You never force any patient to do anything in life, okay? You counsel the patient, you tell the patient, if I am in your shoes, if you are my wife, this is what I would do. And based on experience, but in the end of the day, the one who decide to really what they want to do, and some of them, where I practice now in Dubai, they refuse to take medication during pregnancy, okay? Some of them, they refuse. Nothing I can do about that. I cannot force the patient to take medication. Ideally, they should, because as I mentioned in the beginning, active disease is much worse than potential toxicity from a drug we used, and many of these drugs are quite safe. So I leave you with this. This is where I practice in London and where I am currently practice in Dubai. And many thanks again for the invitation to Kuwait. Thank you.